Special thank you to Mariana for having me give this talk today. Hello, everyone. I am Jarone Lee, one of the emergency medicine, disaster, and critical care physicians here in Boston. And today I'm going to talk a little bit about how telemedicine can help with disasters. And so I have a few different affiliations for this talk. I am faculty at Mass General Hospital, as well as Harvard Medical School, and I am a founder of Health Tech Without Borders. So from all the experience and sort of disaster response, I've been a disaster responder for probably about 10 plus years now. I wanted to talk about some lessons learned of how telemedicine can support our response, especially for the folks who are boots on the ground and deployed. So first is lesson one is that having a hospital in your pocket is key, right? And having the resources of what we normally have as clinicians at big hospitals or even regular hospitals would be amazing since as the deployed clinician, we go into these areas that have been devastated by hurricanes, earthquakes, floods, or anything else. And sometimes we end up being one of the few medical resources available for that community and population. And many of us are used to working in bigger hospitals or attached to a system where we can always phone a friend, call a colleague about anything from like diabetes to anything else. It's just nice to have a support network, even for us within the medical community, especially with the subspecialists. And so to talk a little bit about this, I wanted to step back and talk about a deployment where I'm a federal disaster responder for the US government, and my team was deployed to Florida to support Florida in the Florida Keys after Hurricane Irma. This was many years ago, and as you guys probably remember, Hurricane Irma was a beast. It was massive. It was, I think, about 400 miles wide with Category 4 winds, massively destructive, things that people planned for and evacuated. And as they evacuated Florida, just because of the devastation that everyone expected for it making landfall. And so this is some of the pictures of unfortunately, the devastation in the Keys. As you can see, a lot of buildings were boarded up, closed, a lot of trees were down, and everything that sort of happened there. And from the US government National Disaster Medical Response System, the way it's set up as a quick intro is that there are these emergency support functions, ESF 1 to 15. And the way it's built is it's made to be modular, right? And so for every disaster, it's not always that you need all 15, but you can sort of pick and choose what's needed. For example, maybe a train derailment will only need a transportation ESF1 versus sometimes you only need us, like for COVID, you only need ESF8 with health and medical. And for big disasters like this hurricane, you usually most likely will need all 15. And for our team, we usually go out as a disaster team with all the equipment we need and to be self-sufficient for 72 hours. That usually means that we go down with not just our team members, which is mostly not medical, a lot of logistics and support. It's also trying with these big container trucks with our equipment. Usually multiple trucks come with us. And this is our base of operations or even our field hospital that we set up to start taking care of the population in the Keys. We were set up in Marathon Keys, Florida. And as you can sort of see, we built multiple tents with our equipment. And 4 of these tents were used for patient care. And the other ones we used for billeting and sleeping and our normal, hygiene. However, most of it, as you can see, this was in the parking lot of the City Hall in Marathon, Florida. At this point, there was only one other healthcare system active besides us once we went live, was the emergency department in the Keys. And for a full-fledged hospital that was still operational, was all the way close to Miami, so pretty far up there. And so we were probably one of the few medical resources left, and we were the only few medical resources left in the area for a good amount of time. So this is the entryway where patients would come in to triage. And I just wanted to show you what our resuscitation bay looks like. This is one of the bays. We had multiple bays, of course, but this is specifically for the sickest patients that would come in. And we had all the equipment we needed to take care of them. Like I said, that we bring our own equipment, usually enough for 72 hours so that we don't need a resupply for at least 72 hours. These are the containers that came off the trucks with all of our medical equipment that we use. Similarly, usually we partner with local and national other agencies, including EMS. So these were ambulances detailed to us so that, we can take care of most things, at least in the acute period. And for the folks and patients we had to transport out, we would either go by ambulance or even by rotor wing helicopter as needed. This is a list sort of to show what kind of patients we saw. As you can see, a lot of them were green, lower acuity, who can walk in. We took care of something quick, like a small cut or something, or they needed a vaccine, and then we would send them out. But you could also see, a little over half were sicker than those folks, with a lot of them that were red, which is critically ill, and then black, who unfortunately were sick enough to pass away in our tent. As you can also see that we saw the wide range of ages. We saw everyone from really young kids, less than 6-year-olds, to elderly greater than 65, but we saw everyone. We also saw, some very sick patients that we were able to take care of within the tent for days, where we would essentially admit them and keep them in the tent. One of them was a very nice guy who unfortunately his kidneys failed for various reasons because of the hurricane, and he wasn't able to access medication and water. But we were able to keep him and treat him aggressively for about 3 days, a day and a half, within the tent, and then got him home and had him follow up with us at day 3 and also day 7. And he was doing well, and we were able to keep him at home and within the community. And that's what he wanted. We actually offered to send him to the hospital, and he refused and said, no, you guys can take care of us. Similarly, we were taken care of as you sort of expect, as the healthcare system, people cannot get their medications. The chronic illnesses that people have get worse and get exacerbated. And so we saw folks with like diabetes who couldn't get their insulin and ended up getting deranged sugars, what we call diabetic ketoacidosis, where they get very, very sick from being diabetic. We also saw rashes, of course, as well as, we got a lot of requests to help with animals, service animals, personal pets, especially ones that were sort of stuck at home, especially if they were sick and we had to send the patient to Miami or somewhere else. And so we work closely with animal services and other folks to get these pets out too, and the support they need. But overall, regardless of if we're taking care of someone sick or not sick, or, as a clinician, it's sometimes we're the only clinician in the area. And it's always nice to have a consult to like an endocrinologist for that diabetic, or even, a veterinarian for those animals that might be injured, and everything else that we have to sort of support and work with. And so having a hospital in your pocket, telemedicine, right, where I can call and phone a friend who can help me with anything from pediatric surgery to oncology to primary care, is amazing to disaster areas. Now, I want to also talk about telemedicine and how it supported the United States during COVID. So this is a map of the US. As you can see from the map, this is a map of sort of hospitals and ICU beds, where blue areas are areas with ICU beds and hospitals with ICU capacity. Now you can see that in the orange, there's a lot of places where there's hospitals without ICU beds, which means that they usually don't have any critical care resources and that expertise. And then there's gray areas, where there are a lot of areas where there are actually no hospitals with no ICU beds. And we know from COVID too, is that COVID was going to be and was expected to be a very sick ICU level disease because of how bad it injured the lungs. And as the hospitals filled within the blue areas, those other critical access areas with hospitals without ICU beds are going to have to take care of the COVID patients longer term and longer, and they might not have the expertise needed. And so the US government, to get ahead of this, created something called the National Emergency Telecritical Care Network. It was a joint a project between multiple agencies run out of the DoD, that really stood up a telecritical care program to support these critical access hospitals across the nation. And I'm happy to report for them that I was honored to be a part of this, as Netson covered over 5,000 patient care days across 40 different hospitals in 13 different US states and territories throughout COVID. And this was all at no cost to the hospitals and, of course, funded by the US government at the time. Next is the second lesson I want to jump into is that telemedicine is rapidly scalable to a degree to support people in crisis and people in need. And so jumping to Ukraine, with the Ukrainian crisis, there was, early thought and that the healthcare system was going to be overwhelmed, whether it's by war casualties or even injured by the war, to the point where the general public might and might not be able to access healthcare that they need, similar to any other disaster from hurricane, but with, of course, special circumstances because it's a conflict war zone. And so through Health Tech Without Borders, we put out a call to action very early on, and you'll hear a lot more about this, I bet, from Mariana in the future, about how there was a call to action for both clinicians and also tech companies. And it's amazing what the global community and how the global community came together to support Ukraine and this crisis. And it makes me feel good that, we're all in this together, where we had over 800 clinical volunteers come to us almost immediately and who wanted to help. Similarly, 40 plus health tech, telemed, digital health companies all wanted to support too, pro bono, and wanted to see how their technology can be used for this specific use case. And so, going back for a second, this all came together and we ended up going live with 3 different telemed companies. And over, I'm happy to report that over the last, few months, we've delivered over 62,000 consults within Ukraine to Ukrainian refugees, patients, families, even children who need it. And I'll talk a little bit more about the details later. So lastly, the last lesson I want to talk about is high tech is not always better. It's interesting. We talk about a lot of tech and technology and digital health and telemedicine, but the technology isn't there to be the best. It's really there. What we need is something just to connect people who want to help each other and people in crises, right? And high tech is not always better, especially in the US. When we think about telemed, we think about the new fancy gadgets and video and audio equipment with all the dongles like stethoscopes, but that's not necessarily what people need. And those are cool things. And just to sort of show this, first, I just want to, before I fully dive deep into that, just to show a little bit more work with our Ukraine work. This is a paper that just came out in New England Journal Catalyst about our work with how we rapidly deploy telehealth to support Ukraine. And as you can sort of see from the timeline on the right here, it was messy, of course, because everyone wanted to help. There was an urgency of need. And then, this is beyond the scope of this talk, but I just wanted to show this and show the amazing work the team did, especially special thanks to Mariana for making this all happen. So of all the 62,000 plus consults we saw, it was primarily primary care, right? As you can see, it was, 62,000 of them were some type of general care and prevention, but majority of the rest, pediatrics to everything else, sort of fit into the primary care, general care realm. And I think that what happened was, and for good reason, the hospitals were not able to take care of, and the healthcare systems and doctor offices were closed, right? And so people still needed access to healthcare. Your kid has a fever. You want to talk to your physician or pediatrician or go to the hospital emergency department to figure out if this is something dangerous. And a lot of times, just having a reach out to a telemed program or a physician connection to sort of talk through that and go through the symptoms is all you need to decide whether that kid is sick or not sick, and whether they need to go to the hospital, find a hospital immediately, or something that you can take care of home and closely follow. But as you can see, a lot of our work within Ukraine was all primary care, taking care of the population who needed access to healthcare that was lost. So back to sort of the high tech part, of those 62,000 consults, as you can see, majority, if not really all of it, was 99% of it was through text-based care. And this wasn't like text messages, this was SMS, of course. This was completely through the platform, HIPAA and GDPR compliant and safe and secured within the platform. So it's not just folks texting back and forth on their cell phones, but it is within the platform. However, as you can see, majority of it was text-based. It still doesn't need to be high tech. People just need to connect in some way to talk about their sick kid or family member or their cough or something else. And there was a few video calls, a few audio calls, but for all the reasons that we can talk about, text-based was key in what we did in Ukraine. So back to the United States, and also we'll talk a little bit about some of the work in Mexico. Back to Netson with the tele-ICU and critical care consults. Similarly, as you can see the breakdown, majority of it was text-based between the clinicians as well, supporting. This was all clinician to clinician, right? Not really direct to patient care like the Ukrainian work, but even with clinician to clinician, where we had access to high tech, video, audio, and everything else, the majority of the consults were completed with pure text-based texting back and forth about the patient cases. And this is a picture from Reynosa, Mexico, where we are supporting one of our partner NGOs, Global Response Medical, who are running refugee clinics at the U.S.-Mexican border on the Mexican side. And similarly, we are essentially working with them to pilot a hospital in your pocket type setup where we can offer telemed consults to the physicians and clinicians and otherwise there who need help with something that maybe they're not less comfortable with. And so we've done a handful of consults already, a good amount now actually. And as you can expect, it usually tracks with what the comfort level of that clinician is. I expect that if we had someone who was focused on adult medicine, they usually will consult us about pediatric medicine. And also, we get a lot of obstetrics related ones as well. But it's just something, another resource, like I said, in terms of telemed to have for if I was there, I would love to have. And I think that's all I have for today. Happy to answer any questions. Here's my email. Feel free to reach out. Thank you again for having me.